Now it's my great pleasure to introduce Professor John Hirdes. Just a brief introduction. John is no stranger to us. This is his second time attending our knowledge exchange. The last time was 2 years ago. John is a professor in the School of Public Health Services at the University of Waterloo and is a highly respected leader in interRAI research. He's a member of the Order of Canada, a Fellow of Royal Society of Canada, and a Fellow of the Canadian Academy of Health Sciences. He serves as Senior Canadian Fellow and Board Member of interRAI. He chairs interRAI Network for Mental Health and the interRAI Network of Canada. I've known John for 7 or 8 years now. As you heard before, he's spending time in New Zealand, and John's been very generous with his time. He talked to 3 different radio stations in the last week, advocating the use of interRAI along with the use of AI in health services. So thank you. You're not really having a holiday here. So without further ado, we welcome John to give our keynote. Welcome.
Okay, great. So I'm going to talk about quality indicators and how we can use them to improve practice and outcomes in different care settings. So there's several things I'd like to do here. First, I want to start off by thinking about, well, what are some questions that different stakeholders would ask themselves about quality, and then talk a bit about how we can learn from doing international comparisons with an illustrative example from Canada. Then I'd like to talk about how we design quality indicators, and then make the case for public reporting of quality indicators and using collaborative communities of practice to improve care. And I'll tell you about work that we're doing in Canada on setting a national benchmark on a particular indicator. And I'm going to end by poking at you a bit. You usually come to New Zealand, they say things, well, here's what's happening in Canada, and leave. This time I'm going to try to antagonize you a little bit because, 5 times in a row I've been polite. So imagine yourself that you've got an elderly family member who needs to be cared for in a residential aged care setting. And you've got to decide whether the home is a good home or not. How would you make that decision? Would you go in the home and smell it to see, does it smell okay? And look at it to see, does it look nice? Is this good architecture? How would you know whether it's good or not? If you're responsible as a lead for quality improvement in an aged residential care home, how do you decide what goals you're going to set in terms of improvement for your organization? And how will you know if your organization is improved? And what's possible to achieve for your organization? And how will you know if you've done a job that's good enough? Now, despite the AI insistence,
remember you're asking me to cancel it.
we do have somebody who's not muted online, so if you could mute your phone online, that would be great. So despite a stethoscope not being particularly helpful for quality improvement initiatives, the AI image generation software insisted on that being there, but you can do it without a stethoscope probably. Then imagine you're a political leader and you've been elected with the promise of improving aged residential care in your country. How are you going to show to your voters that you've improved that overall? Now, I think you know where we're going with this, that there are interRAI quality indicators that can be used to this effect, but I'm not sure that in the New Zealand context, you're making full use of those to be able to perform these functions. So let's start off with why it's useful to look beyond your own border to understand quality of care. The first thing is, if you only look at the mirror at yourself, you might think that things look better than they really are. And if you take a broader view of the world, you may start to see there are some things that need some fixing. So I'm going to show you an interesting Canadian example in a couple moments. So what we get from international comparisons, if you're a politician, sometimes we like to sort of say, well, how do we rate compared to other countries or provinces or states? And as long as you're number one, it's great. If you're not number one, it's not as great. This has a lot of popular appeal to sell newspapers and that, but it's not really helpful for quality improvement. The more useful thing is that you can learn about how you can improve care based on what others have done, because by having comparable indicator data from different jurisdictions, you can do natural policy experiments to see what may be possible to achieve in your own jurisdiction. So in Canada, we first started using interRAI instruments on a research basis in 1992. So we've been at this for over 30 years. I was one of the very first researchers in the country to use these data. And I'd just been hired to be the director of research in a teaching hospital in downtown Toronto, a complex continuing care hospital, who the week I was hired, or the week I started, had an accreditation visit. And the accreditation surveyor said, "We think you're doing a nice job here, but one change we want to recommend is that you reduce your rate of physical restraint use in your hospital." The CEO and the board were outraged at these precocious surveyors, and they said, "Okay, Hirdes, you're our researcher. Prove to them that we're wrong." I had just finished a study with the MDS 2.0 in 13 hospitals, so I could look at the rates of restraint use in these different hospitals, and you can see Providence Center is the hospital that I was at. And the conclusion was, well, our rate of restraint use is about the same as all the other hospitals. So our practice patterns were no different from what was consistent in the other hospitals in our jurisdiction. The surveyors, though, gave the right answer. They said, well, we don't want you to do what everybody else does. We want you to lead in quality of care. So that was interesting. I had just been invited to become involved in interRAI, and so I had access to some international data to take a look at. So here are the Canadian rates of trunk, limb, and chair restraint use. So 36% was our rate for any use of those restraints. The international comparisons showed us we had much higher rates of restraint use than any other country that we're comparing ourselves, including the United States. And we hate looking worse than the United States. Then don't talk to me about the United States today. So this slide, as simple as this was a shock to the system in Canada. It helped to galvanize an effort to start to reduce physical restraint use. And now here's our national rate, 4.6%, from a starting rate of over 36%. And what you see is different provinces, when they start, they found the rates are fairly high, and then they reduce restraint use over time. If we had only stood there and looked at ourselves with those Toronto hospital data, we'd say, we got nothing to change here. We're doing the same as everybody else. It was the outside view that changed our perspective. So that brought us to wanting to use quality indicators to drive change in the health system. There are several key design parameters you need to think about when creating quality indicators. First, you need to think about data. So you have to have standardized person-level data. You have organization-level data. You can't assume that it's a correct reflection of the rate of the QI in your organization. You must have person-level data, and it must be standardized. You can't measure things in 10 different ways and do comparisons. The data have to be valid and reliable, both as data elements and in the context of a quality indicator. You have to think about the points of comparison. We could do some cross-sectional prevalence-based indicators, but generally we're interested in changes over time, incidence of events, failure to improve, rates of worsening, and so on. We could think about benchmarking to do historical comparisons of changes over time, but we can also think about we also want to think about how we change relative to other organizations. We don't just want to get better than ourselves over time. We want to get better at a rate that exceeds the rate that everybody else is improving if we want to be a leader in quality. We want to think about what types of indicators we use. Typically, we'll use process indicators, or things that are done to people, like using physical restraints or antipsychotic use, and outcome indicators that are changes in the person's status over time. Most of the interRAI indicators are outcome-based indicators because that's ultimately what you're trying to change in health services. You want to think about exclusion criteria. So in the numerator, who counts as having the event? What's the sign that, yes, the event you're interested in did occur? And the denominator tells you who's at risk. you can exclude some people from this calculation, but if you exclude too many people from the denominator, your quality indicator is based on a weird subgroup. And if you exclude too many people from the numerator, you'll have a very rare event, and it may not be reflective of the overall experiences that go there, that are occurring. You want to think about the timing of events. So when is a quality problem your problem? If you have somebody admitted with a pressure injury, is that pressure injury your problem as an age residential care home, or is it your problem 90 days later when the pressure injury is still there, or when a new one occurs under your watch? And so that's an important consideration for sure. And you have to think about how long does that person have to be under your care for the quality indicator to apply. Risk adjustment is one of the more complicated aspects of this. QI research turns out to be about the most technical research that I've been involved in interRAI research. People often think case mix classification research is tricky, but QI research is more tricky because of these issues around risk adjustment. You will find credible scientists who will make the argument to not risk adjust at all. I think that's fundamentally incorrect. You have to take into account population differences to be sure you're comparing apples to apples across different settings. But there's certainly debate about that particular issue. And so if you were to think about a perfect world of what you're trying to do with quality improvement over time, this schematic is kind of a representation of where you want to be. So at baseline, you're going to have variance in the quality indicator at the start point. You're going to have some organizations that have good quality performance, others that are in the poor range. There's heterogeneity in them. And what you want to have happen over time is that everybody gets better. And ultimately, what you want is that everybody converges on a point with low variance and much better performance than we saw historically. That's the ideal image where you want to be. That's kind of where we got to with restraint use in Canada, but it's a very hard pattern to achieve with outcome-based QIs. They take a lot more effort to move over time, but that's what you're trying to do. Reduce variation between the best and the worst homes and make everybody a good performer over time. All right, so now let's sort of talk about the case for public reporting of quality indicators. And I'm going to show you sort of an interesting experience that happened to me as a researcher in Canada when we basically had a vacuum of information. The basic context in Canada around public reporting in quality indicators is similar to what I understand is the case today in New Zealand. No generally available public reports, but some groups working together to share their QI data internally. So the starting point was an article around 2014 in the Toronto Star, which is one of our biggest newspapers, that said antipsychotic use is soaring in Ontario nursing homes. It was interesting because I'd just looked at antipsychotic use data and I knew that that wasn't quite the case. If we look at potentially appropriate use of antipsychotics, you'll generally see agreement among geriatricians that they should be used with caution. There's lots of evidence of bad things that can happen to the person in terms of psychosocial consequences, falls, mortality, lots of reasons that people are worried. But there's also some conditions where clearly antipsychotics are the appropriate medication. There's much less agreement in the field about using antipsychotics to manage behavior disturbance in dementia. In fact, there's good evidence against this type of off-label use, but there's a core group of clinicians who will insist that antipsychotics should be used for behavior management, even though lots of folks say, no, this is not a great idea in the absence of conditions that cause psychosis. So when that article came out, CIHI had just released a public reporting system called Your Health, or they call it ourhealthsystem.ca at the time. Now it's yourhealthsystem.ca. But that system had gone live, and the antipsychotic QI was one of the indicators that they were reporting on. And so it was a little weird that this newspaper decided to do this special investigative study where they secretly connected with a member of provincial parliament and sort of found background data and did this like, secret agent kind of study to find out about antipsychotic use, whereas they could have gotten it off of the Canadian Institute for Health Information website. And what the CIHI results showed was that the rate was around 33%. The range was between 20 and 50%. And there were variations between provinces, with some provinces having higher rates, some provinces having lower rates. And in fact, the rates were not soaring. They were going up until around 2010, and then they started to drop off. So by the time that article had been published, there was already a substantial reduction in the rate of antipsychotic use. They also didn't know, so within the province of Ontario, they didn't notice that the rate had gone up and dropped down. And they didn't know that in the Winnipeg Regional Health Authority, that rate of decline had been a steady decline and was substantially lower than what they were reporting. And really what we should be looking at is, well, what did the Winnipeg Regional Health Authority do to achieve that reduction in inappropriate antipsychotic use? They didn't have especially high staffing levels or fancy new long-term care homes. They didn't have a psychogeriatrician available everywhere else. They just, wanted to reduce antipsychotic use, and they did it. They also missed a new quality improvement initiative that the National Healthcare Improvement Organization announced, where they were going to mentor homes to reduce antipsychotic use using leaders from that Winnipeg Regional Health Authority. And then they published a bunch more articles. So, they published an article that says, that antipsychotic use is prescribed at alarming rates to seniors in Ontario. Then they had a golden moment for journalists. They cornered the Minister of Health literally by an elevator and got her to say, well, these drugs that are prescribed, they were prescribed by doctors, not by me. And so that was, they loved that to get the minister in deep trouble and create this divide between the system. Then they published an editorial called "Did Zyprexa Kill Aunt Jerry?" So things were getting excited and heated here. And then another study came out that or a report that they produced that almost half of Canadian seniors are given dangerous medications. Another editorial about sedatives and seniors. And then this guy, Tom Walcombe, published an op-ed piece called "Ontario's Casual Approach to Drugging Seniors with Antipsychotics." And that was a surprise to me, because Tom Walcombe was like an international politics reporter. He reported on global conflicts and international relationships, and now he's talking about seniors in medication use in long-term care. So I was at a meeting with the Canadian Institute for Health Information. It was the night before. I was bored. I had nothing to do. I thought, I'm going to send an email to Tom Walcombe and his colleagues. So I sent an email to them about this. I said, well, why did you have to do this special report? The data are already out there. Why didn't you use those data? And why didn't you talk about some of these positive initiatives that are underway by industry leaders? And do you know about some of the methodological problems in the study that they did? Because they used unadjusted indicators. Their report was, or their response was, well, we don't care about provincial averages. We want facility-specific rates to look at. They said, I'm a nitpicker, and that doesn't take away from the fact that they're doing a public service by reporting this information. And they said, we talked to some people at the US Nursing Home Compare, and they don't report risk-adjusted rates either. I said, yes, and the US also uses ICD-9 and the imperial measurement system, and that doesn't make them right either. And it kind of deteriorated from there. So more articles came out, and then they announced a STAR database. They launched their own public reporting system. And so they started to report home by home the rates of antipsychotic use using their data that they've gotten, not the nationally available data. And they published an editorial that says, why does it take a newspaper to provide Ontarians with important government data on nursing homes that house many of our most vulnerable seniors? They said, why isn't this being done by the government itself, or the nursing home industry, independent health organizations, or university researchers. I think I know who they're referring to. And so I kind of had this moment. So, you know, in this case, I'm Corky, the little dog there. So he's looking out, there's a cat dressed as a postal service worker, delivering squirrels into his mailbox, and his head exploded. My head exploded with that editorial that appeared. So we started to take a look at the interRAI quality indicator compared to the Toronto Star quality indicator. So the interRAI QI on antipsychotics specifies a numerator of you have to have had an antipsychotic in the last 7 days. So the denominator is anybody who's got a valid assessment, but we're not using the admission assessment. We risk adjust for a variety of covariates, including motor agitation, behavioral issues, cognition, cognitive performance scale, dementia, and young age. We exclude people with hallucinations, delusions, schizophrenia, Tourette's, Huntington's, end-stage disease, and getting hospice care. And then we do an indirect stratification around the RUG CMI. So very complex risk adjustment associated with it. If you look at the relationship between the Toronto Star unadjusted raw indicator and the interRAI indicator, that's what you see in terms of a scatter plot. You think it looks all right, but in fact, here's the problem. Many of the homes that you would apply the interRAI risk adjuster to would do worse than the Toronto Star indicator, and many of the homes that the Toronto Star indicator made look bad would in fact do better. And so there's a fundamental problem with that raw unadjusted indicator if you wanted to interpret it as a quality indicator and you believe that what interRAI was doing was correct. So then we really started to ramp up the public reporting system. So we thought we can't leave this to the media any further. And so this is the national reporting system. You could log on to this on your computers right now if you wanted, and you would see for individual long-term care homes, this is the long-term care home that's associated with my university on our North Campus. We have several research chairs there, and it reports on things like how many residents are over 85 and under 65, have dementia, have heart failure. But the key thing is down here, we report on specific risk-adjusted QIs for that home, for the chain, for the region the home is in, for the province, and for the country. And there's 1,500 homes that you can look up in this database in Ontario to see their performance on these two indicators and 5 other interRAI indicators. And that's been available since 2013. And this has been the trend that we've seen in antipsychotic use since that time. We've had this long-term trend of reduction. And so you see in blue, that's the province of Alberta. They were around 28% by 2017. They were down to 18%, not the 35, 36% that we saw as a high in the initial reports. You see there's this secular trend of reduction in antipsychotic use over time. Newfoundland, when they came in, stayed high. They didn't change that much. Over time, they did start to improve as well. Then we also established these collaborative communities of practice through Health Excellence Canada. And so if you look at your quality reports, a very common reaction is to say, well, my residents are different. I look bad because my residents are different, or I measured it in a different way. I can't trust the data, or we just can't change this. Those are all bad reactions to give. What you want is a reaction to say, let's do something about this. Let's believe our results are accurate and start to act on it. What you get with a collaborative community of practice is a context to help evaluate your performance so you can see what's possible, what were others able to achieve. You can share your effort to support the innovation. You can do natural experiments where you can try different ways to achieve the same outcome and see what worked. And so you can avoid reinventing wheels or avoid bad things that just went awry. You can accelerate adoption of the things that work, and you can have an emotional support system for when your dearly held ideas fail and you need to move on to other things. So there's lots of benefits to get out of these communities of practice. So this is what we saw with that Health Excellence Canada initiative. Whoops. Uh-oh. No, I did it. Are folks online still seeing the slides? Krista, can you see the slides? Yeah, okay. Okay, sorry. I'm not sure which was the laser pointer for this. Okay, so we had 45 homes that became part of this collaborative community of practice where people from the Winnipeg Regional Health Authority were mentors. They all used interRAI data to monitor the progress and target people and to drive a QI initiative to improve care in this particular quality indicator. And so the intervention homes are the ones that were part of that collaborative. And then the control homes were the 1,450 other homes in the country that were reducing antipsychotic use on their own, but not necessarily as part of an initiative. You can see both of them were improving because it was a national objective to start to reduce antipsychotic use. But the rates of improvement in the intervention homes were higher. They were moving at a faster pace. The other thing that was exciting is that the improvements happened in the best performing homes, the average homes, and the worst performing homes. Everybody got better. And in each case, the parts that the homes that were part of the collaborative community of practice improved at a faster rate than just the secular trend in the country. Everything was going great. We saw this reduction in antipsychotic use. We reduced new prescribing in homes. We increased de-prescribing. New provinces were joining in the initiative. And then COVID-19 hit. Now, it's not a good thing for a number of other reasons. In every one of those provinces after the pandemic, antipsychotic prescribing went back up. We're not sure entirely why. Some said they were told to use more antipsychotics to keep people from wandering in their homes. I don't have a lot of evidence that that was actually true, but I think the efforts to improve quality gave way to let's just keep people alive and let's get through this. And so the foot was taken off the gas pedal for this, and across the country, things went up at a higher rate. And so we are now at a point where we have to think about how do we restart this engine to again initiate antipsychotic reduction after the pandemic. One of the things that we wanted to get rid of was this notion of, well, we need antipsychotics to manage behavior. So we did a treatment effect analysis study where we looked at people who had behavioral issues or no behavioral issues noted at the start, and we looked at worsening of behaviors over time. So 500,000 people in 9 provinces, and we did a treatment effect analysis to adjust for why you get an antipsychotic medication. And what we found in this fancy analysis is that when you adjusted for those, people on an antipsychotic had a 27% odds of worsening their behavior over time. Now, treatment effect analysis isn't quite as good as a gold standard double-blind RCT. It's better than a conventional observational study. There are still some limitations to it, but double-blind RCTs also don't happen with this population on this scale. And so what this does is at least reduces one of those arguments that's been used for justification for continuing to use these medications. And now we're trying to figure out, okay, what do we set as our target for Canadian use of antipsychotics in the absence of an indication of psychosis? So you can see for the country in the pre-pandemic phase, it was going down, then it rose in the pandemic. That's true for Alberta, British Columbia, Manitoba, New Brunswick, Newfoundland, Ontario, and Saskatchewan. I'm not going to use the pointer, but hopefully you can still hear me online. So the question becomes, if we're to set a national target for antipsychotic use, is the target this, the best performing home in the country, the average home? Do I go to a province like Alberta that was doing particularly well? Do I sort of say, well, you know, if we can get back to these average levels, that's okay, but other provinces were exceeding the average level prior to the pandemic. So we're trying to make sense of about what do we do to motivate people. We have a further complication, and that's what we get when we do the comparison with the United States. This shows antipsychotic use in a network of about 65 long-term care homes and 14 organizations called the Senior Quality Leap Initiative. And they're all trying to reduce antipsychotic use, but they all had this increase after the pandemic. If we were to use Canadian benchmarks for good, average, and poor performance in 2017 and US benchmarks in 2012, we see that if you draw a line at the green bars there, most of the homes would have been above that threshold. There were a couple of homes that would have looked at good performance. But by 2017, the US good performance rate was 5%, and the poor performance rate was 13%. And so the Canadian target prior to the pandemic wasn't as good as US performance, and now we were well out of that range. We were looking at these data and we thought, gee, wouldn't it be nice to have data from another country? We couldn't find data from another country for that quality indicator, so we set up a consensus panel. The Canada Drug Agency has now set our target at 15% based on our historical patterns of something that's achievable with a 20% relative reduction per year for about 4 years. We're going to focus on dealing with prescribing of antipsychotics in hospitals, trying to stop new initiation in long-term care homes, deprescribing in long-term care, and introducing more non-pharmacological interventions. But one country that's missing in this picture is New Zealand. Now, all of you have been like this creepy old man on the beach in the trench coat. I've been showing you Canadian data bared down to the bathing suit for the last hour. New Zealand data are not publicly available. I said, we got to see what the rates are in New Zealand to see how do we compare with them compared to the United States. We can't get it because it's not publicly reported in New Zealand. And that's an important challenge because the global community would like to learn from you in terms of what you do to help us understand our performance. You've got the benefit of looking at data from other countries, but you're not playing nice on the beach. Now, for some reason, the creepy old man also has a binocular with 3 lenses on it. I'm not sure why that's the case. Maybe it gives him an additional focus, or he has 3 eyes and we just don't know about that. But we definitely need to have New Zealand benchmark data to inform the global efforts around change. You are an important country. You have a lot to contribute to the world in terms of your innovation. You need to be getting out there and sharing your innovations with the rest of the world as well. But I also want to, sort of deal with one of the reasons I've heard in New Zealand of why you can't share public information about nursing home performance. That apparently you have privately owned nursing homes who are traded on the stock market. These are 3 privately owned nursing home chains traded on the stock market in Canada that are bigger than the New Zealand chains. None of them have suffered with public quality reporting. In fact, Extended Care, which is not the nicest organization in the world, has done great in terms of Sienna Living had a lot of problems during the pandemic, but their stocks have gone up. There's no impact, no negative impact of public reporting of quality on stock prices for privately owned nursing homes. So stop using that as your excuse, but just take it off the table. It's not relevant. You can do this. If Canada could do it, you can certainly do it. But I want to come back to these questions. Do older people in New Zealand and their caregivers have access to those QI data on each of your homes so they can make their own mind up about the quality of care in a given home? Before my dad passed away, he got to a point, he said to me, I'm worried that I may not be able to live on my own anymore because my mom had died 5 years earlier. He said, if I'm going to go into a long-term care home, I want to go into the home associated with my church. He was in the Dutch Christian Reformed Church. I said, okay, let's look them up on yourhealthsystem.ca. I found the 4 homes that were part of his religion, and they were higher on restraint use, higher on pain, and higher on depression. I said, you really want to go there? He said, maybe not. Well, let's look at some of those Lutheran homes instead. And so we found some other homes to look at. I had to help him, But he had the choice of seeing about the performance of the homes he's going in. Does every citizen in New Zealand have that right now in terms of those indicators? And does everybody, every QI team leader in every home in New Zealand, not just the homes that are part of a collaborative network, but every home have data on national performance so that they can see how their homes are doing compared to others? And is your government being transparent with its citizens about the performance in long-term care homes over time? If the answer is not yes to every one of those questions, why not? So I think you've got an opportunity to do something that benefits the rest of the world, but it's also time to use these data to benefit your citizens and the people that are trying to make a difference in your own healthcare system. I hope I wasn't too provocative, but got you thinking. Thank you.
Thank you, John. And we got plenty of time for questions. Maybe we'll start with someone online. People online, you can type in your questions, but I think we got a couple of questions.
Thank you. One question was that enjoyed the slides. Do you have data for more recent years than 2017 regarding the reduction in antipsychotic med use?
Yeah, so the one slide that I showed about, here, I'll just back it up. So this slide is from the public reporting system that shows where we got to in 2017. So I wanted to show you the low point, the best that we got to. 2018, 2019 were kind of flat, and then the pandemic hit and things started to go back up. So one of the key messages about quality improvement is even in the absence of a pandemic, you can't stop working at it. It's a constant effort you have to push at. It takes a lot of energy because you can very quickly slide backward over time.
Any other questions? Naira.
Naira.
Oh, yes.
My New Year's resolution was not to be controversial. But anyway, I'll ask this anyway. Nairi Curtis, University of Auckland. So in New Zealand, we have about half of the facilities which are small and owner operated, and the other half which are part of larger organisations for whatever reason. Yeah. Our current benchmarking are mostly contributed by the larger organisations. So how do you handle the very small home issues and the natural differences? Actually, their residents are different sometimes. I work at the City Mission, and we've got one favourite care home where everybody's a graduate of the homeless sect, and they're really different. So there are some that are really different. And how do you manage that in the public reporting?
Yeah, I mean, those are definitely good questions. So the main issue with the small home is a methodological one where you run out of N and your estimates of the prevalence become unstable, and you know, one resident can make a big difference. There's no magic answer to that. You generally would then pool observations over a longer period of time. Typically what we see is an N of 30 for a QI is a real inflection point for where you can get a stable indicator. So, you know, the province of New Brunswick probably has 20% of its homes are in that smaller category. So that's the way we dealt with it. It's just more observations over time to build stable estimates, which means it takes more time to be responsive to see a response to change over that. And it's the best you can do. There's no magic answer to that. The issue about equivalence of population is at the core of risk adjustment. And, you know, so what you try to do is get the best indicators that can make the populations equivalent, either by trimming people out in the exclusion criteria or using statistical risk adjustment to make them equivalent as covariates. There's always two kinds of pressures that happens. People who want to add more risk adjusters in or exclusion criteria, which means you get down to the smaller, more obscure subgroup that makes the QI not necessarily accurate. There are people who say they want no risk adjustment and who take the view that if you have a resident with an extreme risk of a bad outcome, that's your problem. You just have to do things to overcome that bad risk. And so if I've got, you know, a home for, you know, blind, bedbound, people with diabetes, and I'm looking at pressure ulcer rates, and the other home serves the New Zealand pole vaulting team. That's not a fair comparison. And so you do need to sort of think about making those adjustments. When you get extremely unusual homes, you then have to decide, okay, do I parse them out? And so where I've seen some challenges is where you have homes where 80% of the people have a lifetime history of serious mental illness. It's probably a different kind of population that you can't fully risk adjust with, and that they need a different reference group. But you can deal with that. That doesn't mean that now we can't do anything, because that's one home in a province of 700 other homes that are pretty much alike. And also, the way you want to use this is to drive a conversation. What you don't want to do is name, blame, and shame. You don't want to sort of drag this out to say, oh, home X looks horrible. And the reality is, in the last 15, 20 years, it doesn't happen. I don't see in Canada, the Globe and Mail and the Toronto Star just dying to get the new QI release. They might do something to say, oh, here's the overall trend and so on, and talk to people about the change. But we don't see that kind of shaming behavior, because we've tried to push it out of the culture. And so that's an important thing to sort of work on, that, the reason that we're looking at this information is to drive change. A good thing that CIHI did early on is to engage homes early with their data, so that when some homes said, oh, well, the data for my home are wrong, the question could be asked, well, who's responsible for those data? Oh, I am. I guess I've got to fix it. And so it gives homes a chance to go back to see what they're doing. And also, by publicly reporting, it puts pressure on everybody to try to get it right. The two scariest places to be in a public report are the worst performing homes and the glorious best performing homes, because both are going to be asked questions by ministry or by advocacy groups and so on. And so having this information out there is another way to improve data quality, and it improves the use of it overall.
Couple of questions. If you can introduce yourself before you ask the question, that would be good.
Hi, I'm Andy Inder from Te Whakaora. A couple of questions for you. First, when you introduce the measures, how long do you sort of recommend before you take them publicly, so give people sort of time to get their head around them and adjust? And would you recommend starting with a smaller set and then expanding, or do you have anything in that regard?
Yeah, so the lead up to the original release of Your Health System was about a 3-year wait period. So for 3 years, homes got their data in a cone of silence and could see their own results, and that was their time to sort of work things out and get it right. Now, when a new iteration is released on the website, there's basically a 30-day embargo period where everybody gets their results and can see what the results are on Your Health System site. We had consensus panels to talk about what are the 7 indicators that go on the public site, because if you have too many indicators, people get lost. Even this is hard for a layperson to follow, but all the homes get private reports with all 20 or 25 interRAI QIs for their own purposes as well. So you can use sort of a mixed strategy of what you publicly report. And partly, the choice of the QIs that are there are a reflection of Canadian value systems of what are the most important QIs that we want to drive change in.
Just like,
I'm Ondine Claridge. I'm a Service Development Manager in the Aging Well team in Te Whakaora. I have a particular interest in home and community support quality indicators, and I'm also very interested in the variable reassessment intervals. So that's one of the challenges we have with home care quality, is that we don't have good consistent reassessment intervals. If we're starting to look at that now, my question is it possible to start with very unreliable reassessment intervals and move towards more reliable assessment intervals over time?
Right.
And is there high value in starting with a poor quality of reassessment intervals?
Yeah, I mean, home care has been more of a challenge for exactly those kinds of reasons in the Canadian context as well. In In our age residential care facilities, the mandate is every 3 months so that an assessment happens, which is more frequent than in New Zealand. And that's been the mandate forever. And so there's no controversy about the timing of getting reassessments in there. The home care instrument was implemented province by province and territory by territory at different times, and they applied different standards. So my province initially was doing every 6 months. Other provinces did it once a year, but there's been a bleeding of time between reassessments over time. So some of those are taking longer. It's a fundamental mistake because when you look at the clinical needs of that population, even with our 6-month reassessment cycle, I was seeing clinically meaningful change in 80% of the population within 6 months. And what's happened in our province over time is that the home care population has become more resource intensive. MAPLE scores are much higher than they used to be. CHESS, CPS, ADL scores are much higher. So it's a more clinically complex population. So having these very long reassessment intervals is really not clinically justifiable. So that's the first part. We do have QIs where we can do risk adjustment on time between assessments to try to look at those indicators. And that's at least a starting point that you could use for looking at the home care indicators. I do see a lot more chatter in home care indicators than in nursing home indicators because it's a population that changes more, and 70% of the care is done by family members. And the person's in their own home, they're not in a highly regulated environment. So there's more bounciness to home care QIs, which makes them a little bit more challenging sometimes to interpret. We have started to publicly report on a couple of home care QIs. So in particular, caregiver distress, we now nationally report on as part of a federal provincial funding transfer agreement that the federal government's putting more money into provincial governments who manage and deliver home care services under the condition that they publicly report on caregiver distress. And that transition that we saw to a heavier home care population and a heavier nursing home population has also translated into much higher rates of caregiver distress in our community-based population. So I'm really happy that we're at least publicly reporting on that indicator.
I just want to clarify about the frequency of reassessment in the community. I thought it's every 12 months. I mean, people from interRAI, would you want to comment on that? No? Okay.
Hi, Simone Newsham here, Chief Executive for NASCA. So it's the NAS that do the majority of the reassessments. It varies, and it varies on the basis of resource constraint. I was just saying to Pauline, my goodness, could you imagine the NASC resource that would be required to do reassessments 6 monthly? At the moment, the requirement is to reassess 3 yearly, but earlier. On the basis of clinical indicator. But yeah, the challenge would be the resource requirements for more frequent reassessments.
Yeah, and that's not unique to New Zealand. We have the same kind of pressures, but it's also an artificial challenge. It's a policy choice, ultimately, right? So the allure of home care is it's inexpensive because we're making family do all the work. Right. And so it's a cheap part of the healthcare system because in the Canadian context, 70% of the care people get comes from family members. And so we can get away with not providing a lot of resources into that. The average assessment, should take somewhere, let's say we want to be elaborate, 2 hours. The average time is more like an hour, hour and a quarter, but let's say it's 2 hours. So what's the cost of doing that 2-hour assessment compared to the cost of all the services and resources that are allocated to that person in the next 6 months? It's trivial. So we're blindly allocating resources in people that have changed without reassessing that change and without monitoring the quality of that change that's occurring. And so it depends on one's perspective. If you're looking at it in terms of the perspective of the budget that goes to assessors, yes, this would mean a big increase in the budget to assessors. If you look at the overall budget of home care, it's a drop in the bucket compared to the expenditures that you're making. And if you're driving change in the system to make them more clinically complex, you're really playing with fire. And that's why in Canada, our caregiver distress rates went from 25% to 47% with these transitions. And now we're taking longer to do reassessment. So similar kind of phenomenon happening in Canada, but it all depends on where you think you're saving money and what risk you want to take with the health system. So is it worth it to me to save a couple $100, let's say, on not redoing an assessment when I know the caregiver rate of burnout is going up and the risk of the caregiver and the person being admitted to hospital is going to cost me a lot more than $100 if that happens? Yeah, yeah.
Yeah. I think there's a comment online. Yeah.
Just a question from online. You illustrated your point with psychotics, but are there other quality indicators? Are the other quality indicators as clear to interpret?
The other all quality indicators are harder to see change in. So the process indicators are easier to change because all you have to do is to stop doing bad things to old people. Stop physically restraining them. Stop giving them these medications when they don't really need it. Changing depression and pain and cognition and ADL takes a lot more effort. It's a more complicated thing, and outcomes are more unpredictable and more difficult to manage. We did publish one paper that said, okay, when we had a concerted effort to reduce pain in that Senior Quality Leap initiative, we could drive that change, but it took a lot of effort. So the outcome QIs are much harder to move over time, but you do see variation, and you do sometimes see simple cases. There's a great example, thinking of Naira's example of a small home. There's this video from a home in Nova Scotia that was, a mom and pop long-term care home, and this video was done about 15, 20 years ago. And it follows the director of care. She gets a QI report that says her depression rates in the home are higher than the provincial and national average. And what are you going to do about it? And it sort of follows her through, and she talks to residents and tries to find out what's going on. And she finds out, well, there's things that they'd like to be able to do that they didn't used to do. There's a very simple example of a resident who liked to play the piano and liked to bake cookies. So, okay, let's find a way to let her bake cookies and play the piano. And this home saw real changes in depression rates. So, there's nothing magical about a home with, a university affiliated PhD nursing director. This simple little home was able to make a difference by sort of driving change in that particular quality indicator. So there are some indicators that I think are ripe for change. Pain and mood disturbance are definitely there. Frankly, our pressure injury rate is so low that I don't think it's really worth reporting as a public quality indicator because the baseline rate's about 1.5%. You're not going to do a lot to change that, whereas a depression rate is like 35, 40%. That's where you can really move a lot.
Kia ora, John. Tim Foote. I lead the prevention of abuse of older people work at the Ministry of Social Development. I'm really curious about public engagement with the tool. Do you have any metrics? Like, are people actually using it? I mean, you have with your, parent, but like, are the general public using it?
The media use it. Managers use it. Clinicians use it. I don't think the general public really use it directly. My dad would have never been able to navigate the site without me. And so that's one of the things we're trying to figure out is how do we make it more accessible to the public? But the reality is for many of the public, they will look at the news and the news goes to CIHI as a trusted information source. So in fact, much of the public engagement comes from news pieces that are timed with when CIHI releases the next iteration of that. We're not going to do TikTok videos on QIs. I don't think we've solved the issue of full public engagement. Certainly advocacy groups. This is great value to advocacy groups or to students or researchers. So you can go to a CIHI website and get definitive national information about characteristics in long-term care homes and so you can make the case to say, look, we've got this underserved population or this growing need, but the average person on the street, not so much.
Makes me think of recently, not that recently, but when we were looking for an early child. Oh, sorry. a few years ago looking for an early childhood centre for my daughter, and there's the Education Reporting Review Office publishes reviews every few years of the centres. I think a lot of parents here do look at those. So there's this incentive there around your children.
Right.
Yeah, it's really, I take your point. It's that how do we create that incentive around our parents?
Yeah, yeah. And I think that this is where one of the potentials of generative AI comes into play, to sort of take complex information like this and summarize it in a way that lay audiences can make sense of it. But we need to be sure that generative AI is a trusted tool that actually works the way we want it to work as well.
We've got time for a couple more questions, so you and then Mary.
Kia ora, John. I'm Mary Silcock from Ministry of Health. I work for the Chief Science Advisor. I was interested about the health outcome stuff. Do you risk adjust for the workforce available to the home and possibly to the home care? And also how, because we're struggling with our, making the most of the health workforce.
Right. Yeah, so you would not risk adjust for the health workforce. It would be used as an explanatory or contextual variable. So what the risk adjusters do is they first of all say, okay, who's just not part of this discussion at all? So somebody with schizophrenia, of course, an antipsychotic's appropriate to use. So they're not part of this indicator at all. So that's where the exclusion criteria come into play. The risk adjusters, like cognition, behavioral issues, age, dementia diagnosis, are variables where you would accept a higher or lower baseline rate of the quality indicator for that group. So if you're to look at use of antipsychotics, the risk adjuster says, I'll allow you to have a higher rate than people with dementia, and I'm going to adjust the rate of dementia in your home compared to another home, because I think there will be some natural variation with that. Or if you think about falls, if you were to look at rates of falls, risk adjusting for unsteady gait would be reasonable, because if somebody has an unsteady gait, say due to Parkinsonism, it'd be reasonable if they have a higher fall rate. So the risk adjusters are to make it a level playing field where the baseline probability is either higher or lower based on that characteristic. Staffing levels are structural variables that could be used to explain why a home has a higher or lower rate, but you wouldn't want to risk adjust with that, right? Because what that means is that you would risk adjust, but homes that have better staffing, you'd risk adjust out their rates, and the homes that would have lower staffing levels would not benefit from that adjustment. It's that what you now can do is to say, okay, if all things are equal in terms of the clinical characteristics, does staffing, ownership, location, teachingness, size of place, does that predict variations in quality? And you can look to see what structural indicators drive those changes. Right, so there are some variables that are contextual variables that you use. In the falls example, by far one of the best predictors of a future fall is a benzodiazepine use, but you would not risk adjust for benzodiazepine use because everybody knows they cause falls. So you don't want to adjust for bad practice, and you also don't want to adjust for structural indicators that may explain variations later on. But you want to look to see, are there variations in size of facility, ownership, and then staffing levels may well show up, but then you've got the case to make to say, okay, if we boost staffing levels by this much, we'll see this much of an increment in quality. Oh yeah, you can definitely do that kind of stuff. We have a gap in terms of the richness of our staffing indicators, but my colleague Andrew Costa is one who's doing a lot of work to try to get better staffing data to then link to the QIs. We've done studies to look at size of facility and ownership and language groups and facilities, and not seeing particularly dramatic variations in quality, not as much as interprovincial variations.
Nari?
Could you comment on the IT resource required for managing, say, I think we've got 650 homes and their data in this way?
So the Kaihai site has 1,500 homes and doesn't yet have Quebec in it. That's the only big province that's missing. They're a national organization that has a serious budget to run a national reporting system. They run all the health reporting for all parts of the health system in the country. They probably have 30 to 40 staff members dealing with interRAI systems as part of their national system. I very much encourage you to have discussions between New Zealand and CIHI to see how they do it. There's not a lot of countries that have a CIHI. Most countries that I visit say, gee, we wish we had something like that. And you need to have that independent agency that everybody trusts that can do this kind of reporting.